So I'm glad we are all here. I just counted and saw there were already 115 people connected. So it's great to see all of you here for this very important webinar on community-based primary healthcare in the context of COVID-19. We have, among those many participants, we have participants from Ethiopia, Ghana, Liberia, Pakistan, Somalia, Tajikistan, Tanzania, Zambia, Zimbabwe, Chad, Guinea, Haiti, Madagascar, Mali, Mauritania, Niger, and Vietnam. So it's great to see so many of you connected. I'm very pleased that I can introduce the speakers to talk about this very important session. This session, as you know, is all about sharing experiences among countries and to learn from each other. So maybe I'll ask Louise if you could, yeah, we can go to the next slide. The agenda for today is consisting of us hearing experiences from both Liberia and Ethiopia. And before that, we'll hear from Raj Panjabi, who's the CEO of Last Mile Health and is also at Harvard Medical School, to talk about effective epidemic response that relies on community-oriented primary health care. And the experiences from Liberia and Ethiopia will very much illustrate this and provide a lot of practical information. We will then also talk about what technical assistance is available, what resources are available to you. And we will also make more information available, as we always do at the end of this webinar, with a summary note and links. And nowadays we also have a knowledge and learning page on our GFF website, so there also information will be made available. If you have any questions during the webinar, we kindly ask that you do not put them in the message box, because it scrolls a little bit fast if someone adds something, but to please send the question, if it's in English, to myself, Petra Vergeer. I'm the GFF lead for knowledge and learning and results-based financing, or to Louise Pinto if it's in French or Spanish. And Louise is, you heard him before, he's our senior knowledge and learning officer at the GFF. So we're very, very happy that we're here with such a rich team. I'm, without further ado, going to hand over to Raj so we can spend as much time as possible in answering questions. Raj, over to you, please.
Great. Thank you, Petra, and thank you to colleagues from around the world, not only for joining this morning, but for your work on the front lines. I was mentioning yesterday that I had a chance to serve in a volunteer role in a clinic this weekend that's focused on COVID-19. And I think that there is a tremendous amount of courage that's needed to do this work. And whether you're a government leader or in the finance ministry or the health ministry, or advising and partnering with them, as many I know do at the World Bank and the GFF, there are just critical decisions that have life and death implications. And so we hope today that between our colleagues from the governments of Liberia and Ethiopia, as well as colleagues from the GFF and the World Bank and Community Health Impact Coalition and the Community Health Academy, that we could offer some lessons learned and that are also actively being learned in response to the pandemic that could be useful to you. So I will start, if you could advance the slide, Louise, please, by speaking to the three objectives for today. We're going to talk about why and how community health workers as part of primary healthcare teams are vital for effective COVID-19 response and sustaining primary healthcare systems. The government colleagues will share their experiences in how they're leveraging these teams to respond to COVID-19 now, and then perhaps identify some specific investment opportunities, resources, and connections that can help support your country colleagues in responding to COVID-19. Next slide. I will give an overview for the next few minutes. And my main message in this overview is that effective epidemic response relies not only on strong emergency operations centers and strong incident management systems, but also on the strength of community-oriented primary healthcare that exists within the countries where we all work. Next slide. We know that this is true from recent experiences. In West Africa during the Ebola epidemic, many of my colleagues, including Olasafort, who you'll hear from, and many of you at the World Bank were involved in working with the government of Liberia to respond. You'll remember that there were projections saying as many as 1 million people could or more could become infected, and that many of them would die. Next slide. We remember, all of us do, that during that epidemic, it was in fact not only emergency operations centers and incident management systems, but really workers like nurses on the front line who were charged with trying to respond. And we all remember seeing the courage, but also the fear in their eyes. When that happened, Liberia's community health workers responded by doing what they'd always done. When humanity threatened to, when Ebola and this epidemic threatened to bring humanity to its knees, it was Liberia's community health workers who teamed up with nurses and doctors, next slide, to find the sick, to get them into care, to learn the signs and symptoms of Ebola, to help prevent its transmission, but also to do the contact tracing, to go door to door to find the sick, to get them into care, to isolate those and support those who had been exposed to the virus. Next slide. And ultimately, of course, they used digital tools at that time. Next slide. And ultimately, next slide, by protecting these workers on the front lines with PPE, as you saw, and ensuring that they received the right support throughout the crisis and beyond, Liberia and countries near it were able to flatten the curve, but also bend the curve and eventually get to 0 cases. Next slide. Now, no doubt, Ebola virus disease and COVID-19, speaking as a physician and an epidemiologist, are very different diseases. We all know that. The viruses spread differently. They have different case fatality rates. They have different transmission patterns and therefore different prevention and care patterns. But one thing that is common between the two is that the best emergency systems are likely to be everyday healthcare systems at the primary care and community level that can be surged during a crisis. So that's one key lesson. The other is that, and that is the first epidemic that's critical to respond to, which is the coronavirus epidemic itself. But there is also a second epidemic that occurs, which is from the disruption of primary healthcare systems. So we know when epidemics occur, health workers can become infected if they're not protected. Communities can lose trust in the healthcare system because they're afraid of the disease. They're also afraid of potentially contracting the illness from medical providers. We also know that that all causes a collapse and disruption in primary healthcare. During the Ebola epidemic, we saw evidence of this. There was a 140% increase in untreated malaria cases in Liberia and many in Sierra Leone and Guinea. There was also in the 3 countries an estimated 75% increase in maternal mortality because mothers stopped getting prenatal care, family planning services, and the ability to deliver their babies in the presence of a skilled provider and in a facility. So this is the second epidemic that I know we're all dealing with. But again, here, next slide, community-based primary healthcare approaches can help us respond. In Liberia, there was a 300% or threefold decrease in facility-based deliveries across the country. Next slide. But in districts where the Ministry of Health had invested in community-based primary healthcare approaches, hiring, training, and equipping community health workers, pairing them with outreach nurses, all of whom were equipped with the right PPE, and also ensuring that the clinics had good infection prevention and control, we were able to maintain facility-based deliveries. Next slide. We were also able to see that the drop in the rise in untreated malaria cases across the country didn't have to be in places, again, where there was a strong system of community health workers that were supported well and integrated with primary healthcare teams, malaria treatment, for instance, in Konobo district, remained. Not a single patient missed a treatment dose. And this was because that system that was already in place or was being put in place during this crisis allowed the government of Liberia to modify its clinical protocols. These workers went to a no-touch policy where they empirically treated for malaria without having to do rapid diagnostic test and standing 6 feet away from patients, and that actually saved more lives than caused than causing risk to lives. But it also kept the workers safe and it kept malaria treatment going. Next slide. So this other big lesson is that in epidemics we must try to unite epidemic prevention with primary health care. And if we can do that, if we can unite prevention with care, then we can save more lives from this second epidemic that occurs when an infectious disease like Ebola or COVID-19 affects our healthcare systems. Next slide. So what does it all mean for COVID-19? Well, you'll hear in these two challenges and two strategies, I think, echoed in the country examples that you'll hear from Olasofo-Aduya and from Temesgen Eyahu in the Ethiopian government. The first challenge, which we're all facing right now, is how to achieve rapid and sustained viral suppression, this first epidemic. And we know there's good science around this that many of you are already using, I'm sure. If we think about the viral suppression as a metaphor or an analogy of boxing in the virus, to box in the virus, there are really four sides to the box, and this is borrowing from our friends at Resolve to Save Lives. First, we have to test, then we have to isolate, next we have to find or trace, and of course we have to quarantine. Ideally with social support, given how vulnerable some of the communities we work with are, and also in the context of isolation, make sure those who need care and treatment get to facilities. If we can do these four sides of the box well, we have a greater chance at helping our country partners achieve rapid and sustained viral suppression. But as we know, the quality and the depth in which this has to be done requires if action at the community level. Next slide. So again, here, one strategy that I think you'll hear echoed in the voices of Olasofo and Temesgen is the strategy of engaging community health workers to prevent, detect, and respond, be it through organizing hand hygiene stations or supporting the COVID-19 testing or screening for signs and symptoms and referring them to frontline clinics, or supporting contact tracing where outbreaks are occurring and ensuring that patient contacts are identified, listed, and monitored. All of those are potential roles that I think you'll hear exemplified in the coming presentations. Next slide. We also know that there is success in applying this strategy already against COVID-19, and some of that success comes from our colleagues in South Africa, where the government, along with many partners, have actually taken community health workers that were focused on HIV and tuberculosis for many, many years, and have retrained them to conduct mass screening, symptom-based mass screening, looking for fever, for cough, for shortness of breath, for changes in smell or taste, and going door to door to find those patients who are sick and referring them into clinics. And what we found, what was reported in the Financial Times, is that these workers are meeting some of the testing goals. They have found that 3% of their tests are positive in clinics, but also 3% of their tests at the community level that are being referred from the community level are also positive. So the fact that those two testing rates are lower than 10% and the fact that those are equal tells us that the mass screening efforts by these community health workers are working. So this is an example of the first strategy being used. Let me get to the second challenge. Next slide, please. The second big challenge, again, of course, learning from other epidemics like Ebola, is this challenge of working to prevent primary healthcare system collapse. So many of you are focused on this already at the GFF. I know that there was a press release a few weeks ago by your leadership that warned of a secondary global health crisis, and in fact cited data from this study in the Lancet that showed that there could be an excess of 45% in child mortality and 40% in maternal mortality in the worst case scenario if nothing more is done to prevent the collapse of the healthcare system. Next slide. Again, here, it doesn't have to be. If we invest in the people closest to the problem, in those at the community and frontline clinic levels, if we can ensure that they are given sufficient PPE, that infection prevention and control protocols are in place, triage is created, respiratory illness clinics are put in place, and that protocols are modified, protocols for delivering family planning services or for delivering malaria services, for instance. If those are in place, then we have a better chance of mitigating these excess deaths. And again, you'll hear this from Olasiford and Temesgen, and how those countries are taking some pioneering approaches on this second strategy to protect primary healthcare workers and to modify primary healthcare protocols. With that, I'm going to turn it back to Petra to introduce Olasiford.
Thank you very much, Raj. That was very helpful. I'm very pleased that Olasiford Wia, who's the Director of Community Health Services from the Ministry of Health in Liberia, is here willing to share his experiences from the lessons from Ebola and what they're doing now. So, Olasiford, over to you. Thank you.
Good morning, Petra. Good morning, Raj, and good morning to everyone. From Liberia, we are grateful to be part of this. To see that there are many people cut across the world part of this discussion. So we're going to attempt to provide information and as to process. Next slide, please. Raj have touched on a lot of the things, giving historical context into our community health program. So I will skip most of them and prefer to go to speaking on mainly some of the issues that we are currently doing in Liberia as per the COVID-19. Can you please skip to the next couple of slides? Okay, so Liberia, upon the first case that was announced early in March, prior to that time, we have been engaging our partners and other stakeholders at the national and subnational level to develop a policy or a protocol that will help us to deal with this new wave of pandemic. So what we had to do is to gather together some resource material from WHO, CDC, and other sources, and form a technical working group that will be able to look at our three most strategy. That is response, detect, identify, detect, and then response strategy that we had in mind. Prevention, detection, and that of response strategy that we have. So we formed this group, and the technical working group were able to develop bits and pieces of all of the strategy that we had in mind, and we had a very detailed protocol to help our community health worker to be able to implement. And now, we thought this was very important because looking at the trend of the disease, knowing that this was a new disease, different from Ebola, and we were still learning as to how to deal with it, we thought one of the ways we could strengthen or support the healthcare delivery system from our own end as community health workers is to ensure that we are part and parcel of all of the response strategy. Now, one of the things that we thought we could do, how can we get the community health worker involved into the testing aspect of the response? Raj mentioned 4 different aspects of the response. That is the testing, the isolation, funding, and that of the quarantine. How can we effectively make sure that community health workers are deeply involved with these processes? Now, what we did is, after all of this process of reviewing resource material, we were able to conclude and complete on this protocol that we were able to submit to the IMS, and it was accepted. Now, in terms of the prevention, we were looking as to how a community health worker can encourage, mobilize and encourage their community members to adhere to the hygiene protocol, hand hygiene protocol, social distancing, and that of using of face masks. We also thought it was important for them to participate in the aspect of triaging people within their community, especially those who are suspected. And that has been going on. In the early days, we were able to ensure that the community health worker, especially in Montserrado County, that is the epicenter, was able to work with a community that was very aggressive and was able to resolve some of this aggression in those communities, making sure that we were able to safely isolate suspected people, and then working with the community to identify temporary isolation sites within the community until we can get to the surveillance team to come and pick up those persons from the community. The second issue in terms of the detection, community health workers have been trained to be able to do active case funding. That is important. We think that is very much important, because if we are to reach our ultimate goal and objective to flattening the curve of this pandemic, we must be able to spot out these suspected ones in the community and be able to isolate them safely from the community, so that we keep the community safe. So these community health workers have been trained, and they are deeply involved into active case finding and contact tracing of suspected contacts. The other aspect we have also been able to do is to ensure that we participate in the response phase of the crisis. In other words, making sure that we have community health workers to effectively respond to their community in terms of, one, after being identify these cases in the community, they should safely isolate them and then promptly inform the requisite authority, that is the surveillance team, to come and quarantine these people from the community. We also have to ensure that we protect these community health workers with the appropriate PPE so that they can also be able to do their work. The last piece to our strategy, COVID-19 strategy, when it comes to community health, is to maintain our routine services. We think that is very important. We cannot let the COVID-19 to create further gap in a healthcare delivery system, and knowing that will have a huge ripple effect on a lot of the services that have already been provided. So we have to develop a strategy that will have these community health workers to continue to provide their routine services while responding to the COVID-19 activity. And one of the ways we have to do that is to look at all of the key activities or services that is being provided, especially for children under age 5 and that of for pregnant women. How are we going to ensure that the community health workers continue to provide these services at the same time staying safe? So we had to, one, develop different scenario for them to be able to do it. If the community health worker is equipped with the requisite PPE, basic PPE, that is face masks, hand gloves, and then they should be able to do, for example, RDT for a sick child who is under 5, or to be able to provide a family planning commodity. For example, the sign and press that we are providing in parts of the country, example, in references, we cannot, the community health worker needs to continue to provide those services, especially to mothers or women of childbearing age, so that they can continue to keep safe. And the only way we can do that, protect the community health workers, keep them safe so that they continue to do their work. So with all of these pieces, we were able to put together a detailed, easy to understand job aid for the community health workers that they can use continually in their work. And thanks to all of the partners that participated in that process. In fact, as we speak, there have been a lot of printing of these materials, and then we've been able to give it in the hands of the community health workers and making them to be more confident to do their work. Lastly, from my own end, I think one of the issues that we thought was very important was to break the fear in the community. That is very important, and because of the fear, the health system in Liberia have begun to experience decline in service delivery. People have not been going to the facility for services. And even those who may muster up the courage to go there, they trust as to whether they may not get infected at the health facility was another issue. So we have to deal with all of these things and making sure that we provide the requisite information to the community health workers to be able to help their communities in breaking in the fear and restoring trust in the healthcare delivery system. It's an ongoing process. We are still into it, but from recent information coming out from all of the counties, we can see a few of the counties that are in a response phase are experiencing tremendous results from these actions from the community health workers. Montserrado County is a specific case. We are still trying to deal with Montserrado. We are in the process of ensuring that we implement a robust 2 weeks massive engagement with the communities, especially in the hotspots, so that we can be able to break out the fear and ensure that there are more people who can get tested in the soonest possible time. So it is
Hollis Ford, I think we've lost you for a little while.
It might be best to move on to Temesgen, Petra. But,
yeah. I was just thinking the same. It looks like Lasford's connection is frozen. So I suggest we ask Temesgen to kindly speak about the Ethiopia experience, and we'll come back to Lasford in a little bit later. Temesgen Ayehu is the director of the Federal Ministry of Health in Ethiopia, and he's the director of the Health Extension Program and Primary Health Care. and he will speak to you about the use of technology to empower primary healthcare teams and communities with the information they need. I already saw a question related to that in the chat box on how are these people trained. So I think it's a very good that you will be talking about this, Mesken. Thank you.
Thank you very much, Petra, and hello everyone. So I'm going to speak shortly on two things. The first one is how we are using the existing community health program, which is a health extension program for this COVID-19 response. And the other thing is, as you have seen from the slide, on how we are using technology, especially to provide needed information for these community health workers and primary health care professionals so that they can provide the needed information for the community. The next slide, please. So, as you may be aware of it, the Ethiopian Health Extension Program was launched 15 years ago, and the intention was during the launch of the program, the main objective was to provide promotive, preventive, and basic curative services to Ethiopia, especially targeting the rural people who are living in the rural areas, and accordingly, 2 health extension workers, mostly women, are assigned almost in every village to provide these services. And currently we do have around 40,000 health extension workers providing these services. And the services include health education, health promotion, hygiene and sanitation, and also prevention of major communicable diseases. So as part of the COVID response, the first thing that we do was to develop a guideline clearly stating what is the role of health extension workers for this COVID-19 response. And that guideline was translated to 5 major local languages, and it was distributed to all health extension workers. And in that guideline, we clearly state that we identified around 5 main roles for the health extension workers to play for this COVID-19 response. So the first one is to conduct house-to-house case finding and also referral. So the health extension workers, in collaboration with other community leaders and also security personnel, they will go house to house, and also they detect cases and they refer with the isolation and rapid response teams. And the other activities that the health extension workers are doing for the COVID-19 response is risk communication and community engagement. So while doing the house-to-house case finding, they also provide health information to the communities on what COVID-19 is, how it is transmitted, what are the prevention methods that each household and community practice. So they provide this health education through their house-to-house visits and also at the community, and also while providing their services at the health post level. And the third one is they also support the contact tracing activities that's conducted by the rapid response team at the district and health center teams. So since these health extension workers have been working in the community for the last 15 years, and through the support they gain from the community while providing these services, they are very good also partners, especially for the rapid response teams for this contact tracing activity. So that's one of the activities that are currently doing. And the other thing is, like, after the first case of COVID-19 was reported, there were a lot of volunteers to help, including in the health education and contact tracing and all other activities. So there must be someone to coordinate these activities, especially at the village and lower level. And currently, the health extension workers are the ones who are coordinating and leading these volunteers, especially in the rural areas. And the other most important aspect they are doing is, like, while doing their COVID-19 response, they are also expected to provide to continue providing their routine services, whether it's at the health post level and also while they are doing house-to-house visits and so on. So, like, for example, in one of the regions, in one of the towns in Ethiopia, a week before, while they're doing the house-to-house case finding, they identified around 27 people with fever symptoms, and almost 20 of them were diagnosed to have malaria. So this is also one of the activities they are doing, but they also still continue providing other services at the health post and also community level. And the other things, they also provide psychosocial support for people like maybe where the cases are reported, or for especially also for the recovered cases. So this is activities that we outlined for the health extension workers. And as you have seen also, as you can see from the slide, like the report that we have last week, especially on the house-to-house case finding, is like after the activity was started, around 3.6 million households were visited by health extension workers and their teams, and around 2.3 people were screened for acute respiratory illness symptoms, and out of them, nearly 1,000 of them were identified as suspects, and also nearly 900 and 1,000 of them are linked with rapid response teams. And out of all this process, one confirmed COVID-19 case was found. This is a huge activity, because at that before a week, and also recently, since there is not a huge community transmission, to get one confirmed case also, it has a huge impact. But they nearly reached 3.6 million households with information on COVID prevention and control as well. So one of the reason why we prioritize to engage community health workers or health extension workers was like the main communication tools to reach the communities, like radios, TV, mobile phones, and internet access to the community, especially in rural Ethiopia, is very limited. To see some figures, like according to the Ethiopian Demographic and Health Survey, which was conducted in 2016, for example, access to radio is 24.1% in rural Ethiopia, and access to television is around 2.1% in the rural population. In mobile phone access is 47.2%, which is relatively good. But the internet access, especially women, only 5% of them have access to internet. And like if you see the social media, only 6.27 Ethiopians have Facebook account, like for example in 2019. So the common ways of communication to reaching the community is very limited, especially in rural areas. So using community health workers and health extension workers is one of the best strategies to reach communities. And also the health extension workers have a better acceptance by the community, because these health extension workers were providing immunization and childhood treatment and also antenatal care and other services to the community. So using these health extension workers and providing the health information to the community is one of the best strategies that we have identified so far. Next slide, please. So, as I said, prioritizing health extension workers and community health workers is good, and they are also reaching the communities. But we need to have also a mechanism to reach these health extension workers and primary health care workers to provide them up-to-date information on COVID-19 prevention and response. So with this COVID-19 pandemic and also with the physical distancing, it's very difficult to provide trainings using the face-to-face training approaches. So we work with our partners and we come up with two solutions. The first one, what we worked in partnership with Amref Africa is using ELIP mobile health training platform. It is an interactive voice response training, voice response platform. So it has both SMS and audio training platforms, and our targets are health extension workers. And the good thing is, like, since these health extension workers are living in many rural areas, and most of them, they do have basic phones. So this LIP platform, it works on both basic and smartphones, and it has interactive learning, so it has quizzes, practicums, lectures, and also it has collaboration and interactive through group chats, and we can also monitor the progress of the health extension workers using the platform. So one of the technologies that we have chosen is this LIP, or the interactive voice response platform, to train health extension workers so that they can get up-to-date information on COVID-19. The other thing is we also developed an application in collaboration with Last Mile Health, and this one is a COVID-19 Ethiopia. It's called health worker training platform. So it has was a multimedia. It's a multimedia aided COVID-19 information and training content, and also we targeted all health workers, especially who are working in the primary care facilities, with access to smartphones. And the trainers, they can access to learning activities, videos, and quizzes offline. And it has also some like points and badges to motivate people to finish the training. And it has both text-to-speech function. And all 6 courses were developed by the Ministry of Health and the Ethiopian Public Health Institute, which is currently leading the COVID-19 response. And all these courses were uploaded. And currently the app is being used with APK file, especially in Addis Ababa. But we are also uploading that application on Google Play Store. So using these platforms, we are able to reach the community health workers and also the primary healthcare workers with up-to-date information as soon as possible. And currently, the 2 platforms, it started already in Addis Ababa, in the capital Ethiopia, and we are planning to reach almost all of health extension workers within the coming 3 weeks using this LEAP platform. And the primary healthcare facilities also, they will receive the training using the COVID-19 Ethiopia. Because also in Ethiopia, the health extension workers and also the primary healthcare facilities, health centers, they are serving as one primary healthcare unit. So it will be good to, the information is also linked with these 2 applications. And the primary healthcare units are the one providing supervision to the health extension workers. So the 2 applications are also complement each other. And the health extension workers and primary healthcare workers are will get up-to-date information using these 2 platforms. Thank you very much.
Thank you very much, Temesgen. I'm sure that was very interesting for many. I am very pleased to ask Madeleine Ballard, who is the Executive Director of Community Health Impact Coalition, and she's also an assistant professor at the Icahn School of Medicine at Mount Sinai, to talk a little bit about the priorities for the response and some of the challenges. And then I'm also asking Magnus Conte, who's the Executive Director of the Community Health Academy at Last Mile Health, to speak to you about what is next and what resources and assistance is available. For those of you who are interested, in case you connected later, you can find the slides in the documents folder on the right in both English and French. Madeleine, over to you, please.
Thank you so much, Petra, and thank you, Raj, Olasford, and Temesgen for setting the stage in terms of what's at stake here in this response. We wanted to now turn our attention to, we've gotten a bit of a sense of what we need to do and how it's being done in Liberia and how it's being done in Ethiopia. We'd now like to see what resources are available to make sure that it's being done, and you are all equipped to make sure the response is happening in your own countries. Next slide, please. So what we heard from the presenters thus far, next slide, please, is that we need to do 4 things. 1, as Raj said, we need to achieve rapid, sustained viral suppression. So we need to interrupt the transmission of COVID-19. 2, as we heard from Raj and also Olasford and Temesgen, we have to make sure that we are maintaining routine health services, maintaining existing health services, and surging their capacity. As Raj said, the best emergency system is an everyday system that can surge in a crisis. The 3rd thing we need to do is make sure that in the midst of all this, we're shielding the most vulnerable. And as we've discussed, both Olasford and Raj, community health workers, in the sense that they're pre-existing, in the sense that they have this link of trust with their communities, are really well placed to do this. In order to do 2, 3, and 4, however, we need to protect health workers. And this is something that we as speakers decided that we wanted to also emphasize at this moment, that in the first 8 to 10 weeks of the response on the continent and in many low and middle income countries, we see, of course, that PPE has emerged as a key bottleneck in the response. Without it, of course, community health workers can neither interrupt the virus nor maintain health services. And we're seeing barriers both in terms of an absolute shortage of PPE, but also in terms of inequity in PPE access, wealthier countries outbidding poorer countries. But even within countries, we're seeing issues the exclusion of community health workers from national projections, the fact that community health workers are often not counted. We want to focus on this last bucket because we feel like it's a place where all of you on this call can actually make a big difference, not only in terms of counting community health worker cadres in your countries, but also ensuring that PPE is allocated based on the services being provided, not the service provider. And we hope that Raj and Olisford and Temesgen have made the case that community health workers are essential, both, again, in combating COVID and also in maintaining health services. And so they're very much worthy of being protected like any other health worker. But how do we do this? Next slide, please. That's what Magnus and I want to zoom in to now quickly to set the stage for our discussion, where we hope we can dive even deeper into many of these resources. The 5 quick things we'd say are: 1, get the evidence. As Raj and Olisford noted, there is a large body of evidence in terms of what community health workers can do whilst responding to epidemics, Ebola included. And we've linked a couple of resources in the slides. You can see not only a bit of a resume on CHW's roles in these crises, but also a deeper description of how community health workers have already begun to prevent, detect, and respond in this crisis. The second is, we'd encourage you to trade notes. We have this platform here today, but we know that operational and programmatic issues will continue to evolve over the course of the response. We have these calls every Friday at 11 a.m. Eastern time. They're open to all. We have people from many different agencies and 4, 5, 6 different WHO regions coming together to solve for the nitty-gritty operational issues that come up when trying to do this. Things like Temesgen mentioned, how do we modify protocols? Things like Olisford mentioned, how do we get supplies where they need to go? So we'd encourage you to connect with your peers because, again, there's no need for everyone to reinvent the wheel. A lot is being done in real time during this response, and it's great to borrow and exchange with those who are all in this together. Fourth, we'd encourage you to share your resources as they're being developed. So here we've linked a Wikipedia page that has a lot of explainers on COVID, a lot of different materials around the response, as well as an actual protocol resource wiki that has the actual materials used in many countries, from India all the way to Malawi, to train and equip community health workers. And we hope that not only might those 2 resources be helpful to you, but as materials are being developed in your countries as well, that you would edit and add them to these wikis. They've been ongoing for some time now, and I think can continue to be helpful, again, as the response evolves. We'd also encourage you to use your power, make concrete plans. As we noted, some things are beyond our control at country level. Global supply shortages, for instance, export bans, but a lot of things are within our control. Planning, stewardship, counting community health workers, how PPE is allocated, how projections are made. And so we want to encourage you in that and equip you to do that in the best way possible. And finally, to echo again Raj's point, the best emergency systems, we've seen this over and over again through time, are the systems that can be surged in a crisis that exists prior to that crisis. And so we also want to highlight that this is an opportunity. The investments in compensation and continuous training and performance management that are needed to actually rapidly deploy contact tracing at community level, or rapidly deploy test collection at community level, or rapidly deploy, as in Ethiopia, messaging at the community level, are the same as those required to prevent the next pandemic. So we also want to encourage you to use this as a moment to advocate for the strengthening of this cadre in general, and note that there are a number of available tools like the AIM tool for program planning and design, or the MSH UNICEF tool for program costing that already exist that can help in this endeavor. And I think Magnus is going to add on with even more recently developed tools at this point.
Magnus, you're on mute. We can't hear you. Can you try and... No. No, I still can't hear you. You might have to refresh your page, but it looks like you're muted. I have a red microphone with a cross through it. No, it's not working. I think we just lost him.
Oh, Petra, I can present some of what he was going to share if that's useful, or we can wait for him, whichever one.
Magnus is coming back in a second. He's just refreshing his page.
Yeah, and I don't know, is Olisford back?
Can you hear me now?
Ah, yes, now we can. Perfect.
All right, the power of technology.
Great.
So,
go ahead, Magnus.
Thank you. Bonjour, tout le monde. Thank you all for the opportunity to give this presentation, and thank you to Raj and Madeline for setting the stage. But my special thanks go to Olasford and Temesgen for the leadership they are providing at the front lines, particularly at this challenging time, but on a day-to-day basis for preparedness, as well as helping to build capacity at country level. And during this type of emergency response, pandemic response as we have, particularly in the context of social distancing, providing or continuing to be able to provide capacity building becomes very challenging. And this is where already presented by Temesgen, the ability to use digital technology and training apps actually becomes quite urgent and necessary. And as part of this response, the Community Health Academy, which is established to provide health workforce capacity building globally, and particularly for those community-based health workforce who are the front lines trying to provide healthcare for local community members. Capacity building for that health workforce is quite critical at this point in time. And as a result of this, the Community Health Academy at Last Mile Health is currently leading a consortium of organizations in establishing the COVID-19 digital classroom. And our purpose is to create a rapid sort of quality, accurate, and relevant information for communities and for training, of course, the community-based health workforce. The COVID virus, it's quite a tricky one. Besides the fact that it is infectious, the knowledge currently that exists is limited, but it's rapidly changing as the science and knowledge increases. And therefore, what we are trying to do through this digital classroom is, first of all, to curate existing content that is available globally through WHO, UNICEF, CDC, and other global institutions, to make that available in a repository. Within that repository also, we are developing new content based on existing knowledge, but also the emerging science and knowledge about this virus in terms of its detection, prevention, and management, and making that knowledge and training materials also available on our online repository. Thirdly, we are inviting other organizations that are doing similar work, but work that is of high quality, because as you all know, there is a lot of misinformation out there. There is lots of information, lots of training materials, but some of those materials and some of that information is of questionable quality. So we want to make sure that we can invite reputable organizations that are providing high quality training material and make that available also on this online repository. So with every classroom, more often than not, there is a library of resources that learners could access. So we are establishing the COVID-19 library, which is also accessible online. It's a digital platform that is linked to our digital classroom. Next slide, please. Next slide. Thank you. As already presented by Temesgen, in Ethiopia, the Community Health Academy is supporting the Ministry of Health with the launch of this digital platform, which is powered by the Oppia mobile technology. And similarly, in Uganda, we're working very closely with the Ministry of Health. They have also adopted this platform. And both Ministries of Health, together with the Ministry of Health in Liberia, that also adopted this platform even prior to the COVID outbreak. These three Ministries of Health have developed content with the support of partners, and that content is now being made available on this digital platform, which has multimedia capabilities with videos, animations, podcasts, gamification, and built-in analytics to track the journey of the learners as they are accessing the content, as well as taking the tests and quizzes. And the Ministries of Health are then able to harvest the data from the device and be able to assess how many learners are taking the content and how they are performing, but also take feedback as to how we can continuously improve not only the performance of the application, but also the training content. We also then have the Community Health Academy platform, which again is a digital platform, is a learning management system that is free to access, and we are making training content available on that platform. That platform is going to be launched on the 1st of June, together with the digital classroom landing page, which will also give you access to the library. So these are new resources that the Academy is launching in partnership with Core Group, Translators Without Borders, who translate the content into different languages, as well as Tech Change, and Medical Aid Films that help us to develop the content, including courses and animations. Next slide, please. Next slide. So with all these training resources that I've just mentioned, there are tons of opportunities for collaboration with the Community Health Academy to provide access to learning content, but also content that exists at Ministry of Health level. We can work collaboratively with Ministries of Health to upload this content by digitizing it and making it available on the learning management system online or through the mobile-based platform, which is the one that Ethiopia, Liberia, and Uganda are already using. Next slide, please. Next slide. So I would also like to mention another online facility that is available that has been developed under the leadership of the Gates Ventures, which is the Bill Gates office, which has brought together a number of organizations as well to undertake what is being referred to as exemplars in global health. There are 5 areas that were considered in terms of stunting. A research partner, Sick Kids, undertook research into the treatment of stunting across a number of countries and to identify those countries that have performed very well, that are referred to as exemplars. These are countries which are positive deviants. They have shown how best to address some of these areas. Under 5 mortality, and of course, Last Mile Health was involved in looking at community health worker programs. for vaccine delivery as well was undertaken. Some research was undertaken in that area to again identify those countries that perform very well, as well as in neonatal and maternal mortality. This was brought through a core team of researchers and analysts that were able to analyze how these programs perform so well in such an exemplary manner for them to be identified as exemplary programs. And this has now been made available on a web platform that can be accessed freely. And through that access, strategic partnerships could also be established to look at how that information could be translated at country level in terms of how countries could benefit from that. Of course, there are tools and pathways for dissemination of both the knowledge that has been gained through this exemplary work, but also how this could be translated at country level. There is also the possibility that a hands-on technical advisory services could be accessed by countries to ensure that this knowledge can be transferred at country level to specifically address country needs as we try to improve global health at country level. Next slide, please. I think we're going to skip the next couple of slides and come to an end of my presentation. Thank you.
Thanks very much, Magnus. Much appreciated. Very, very helpful. I already have received questions, so there's a lot of interest in this. So I'm just gonna say that if you have a question, we will have a whole group of people you see here who can help answer the question. I understand Opope is not well, so she's not joining today, but we have others from Liberia on the line who can also help respond. Can I please ask you to email the questions? And Louise, maybe you can show the slide with our email addresses of where to email the question to, rather than put it in the message box, because it's a little difficult to follow. We're using this Kudo platform that's a little bit different than what we often use, because it's the only platform we know of that can allow for simultaneous interpretation in English and French and Spanish. So if you have a question in English, send it to myself, Petra Vergeer, and you see my email address up here. And if it's in French or Spanish or Portuguese, you can email Louise, and then we will start responding to your questions. So I already started with some questions that I have received. The first question is related. It comes from Chad. How to overcome the problem of the shortage of drugs and consumables for sexual reproductive maternal newborn child and adolescent health care when all transport is interrupted, apart from the special flights for drugs, materials, protective equipment against COVID-19. So that's a question we have been discussing in an earlier webinar where we spoke about supply chain. So it might be good for colleagues in Chad to also have a look at our knowledge and learning page on the GFF website, where you can still access that video, which has more information on this. But I'll also give Madeline an opportunity to respond. And at the same time, there's a question whether if these community health workers were relieving health personnel that have been redeployed elsewhere. So maybe I can ask Temesgen and Olesford if he's back on the line. Not yet. So maybe Temesgen, if you can comment on that. So Madeline, I'll start with you. And Louise, can you maybe mute your mic? Go ahead, Madeline.
Sure. Thanks, Petra. So we have done a lot of work on the shortage of PPE, which is not quite the same as what's being asked about, the shortage of drugs for social and reproductive health, materials for social and reproductive health. But many of the barriers, I think, are a little bit the same. Again, we have the case of PPE, there's absolute shortages. In the case of these drugs, perhaps not so much, but there are certainly inequity in access, and there's probably an exclusion of certain levels of the health system. And so we see those two parallels. And so I certainly can't offer a panacea, but what I can say that we've seen are a couple of things. One, that we've seen advocacy from within the country level on restrictions on spending, aid money or certain earmarked money, whether it's on PPE or extra supplies. And I think there was an encouragement even in the last couple of weeks to try to push as much material down the supply chain as possible so as to make more room to bring things into ports. That's obviously now perhaps a bit of an irrelevant suggestion in many places given the transport restrictions, but insofar as it's still possible, that's something that we can do to stay ready so that when opportunities arise in an ad hoc manner, we can bring materials into port. We've also seen another strategy whereby we've special appeals to not just multilaterals and bilaterals are made, but also private capital. I think we've seen strange stories like Warren Buffett using private planes. And all to say, I think lots of scrappiness is being demonstrated. And it's certainly people are using creative channels in the absence of the typical channels being available. And again, that's not something I can give you a list of, but that's something where, as I mentioned, getting on the phone with peers or countries in the region to try to put something together in an ad hoc way. We've seen some success with that in various places. And then, finally, I would just say that I think, again, in terms of distribution, when shortages are being faced, that's when making smart allocation decisions is important. I know there's guidance on that, as Petra mentioned, and that's worth looking up. So certainly, these are difficult issues, and I know that that's not such a satisfying response. But those are a couple of leads that we've seen folks pursuing from all over, and I welcome colleagues to add in if they have other thoughts.
Thank you. I might also ask John Barrazo, who's on the line from the GFF, if he could join and request to speak, and he may also want to comment on that. So maybe I'll go back to Temesgen first on the question, and then I see that Olesford is also back.
Sorry, Petra, would you please pardon the question once again?
Yeah, so the question is, did the community health workers relay or relieve the health personnel that was redeployed elsewhere? So are they doing things that health staff that is maybe now moved elsewhere is doing, or is it a different aspect?
No, currently the health extension workers are doing what they were expected to do previously, because they are working at the health post level, like for the last nearly 15 years. And currently they are integrated the COVID-19 activities in addition to the health extension program package, what they are doing before. So there is no additional task they are doing, but only the COVID-19 activity, and they are integrating that activity with the health extension program package, what they are doing previously. So there is no any other addition.
Thanks, Temesgen, and I think it might be the same for Olesford. Olesford, do you want to talk about that question in Liberia, and maybe we can also at the same time pull up the last 3 slides that you did not yet have the opportunity to present.
Thank you, Petra, and sorry that I had to lose connection. So currently in Liberia, we have the community health workers involved into their routine activity, and with the coming of the COVID-19, it is now becoming, it's now become a part of their activity. So they are more of increasing the linkage between the primary healthcare facility and that of the community, so that we ensure that services at the primary healthcare facility can continue. But more importantly, we've seen of recent that the maternal and child health services at the primary healthcare facility is declining. So we are currently in consultation and discussion with the reproductive health division to be able to see how we can have these community health workers provide some ANC services at the community level in terms of follow up on pregnant women, and if possible, doing some basic checks up for these pregnant women in their community. We think that is very important if we are to avoid pending maternal and child health issues, especially maternal and child death coming from the communities. So that discussion is ongoing, and we have a plan to ensure that we implement the RED and REP approach, reactivating that approach and making it part of the routine activity for community health workers in Liberia. Over to you.
Thanks, Alasford. And I know people were already wondering if they could get a copy of the slides, of the protocols and the documents and so on. So I know you have already offered to do that, so that will be very helpful. And I know Temesgen is saying the same. There's another question that is linked to training. And I think it was already addressed a little bit, but I just want to make sure it's very clear. Who exactly are community health workers? Are they professional medical workers, or who exactly, what's their background? And because if they're tasked with prevention, diagnosis, and treatment with the limited training, they might be at risk, or they might, of course, also transfer COVID in that situation. So maybe I'll ask Temesgen to speak to this a little bit from the Ethiopia experience that you raised, and then maybe Alasford, you also want to come in from Liberia, and then I don't know if Magnus maybe wants to add.
Thank you, Petra. So according to in our country and the Ethiopian context, community health workers are called the health extension workers. And as I said, almost majority of them are female, and their education background is they finished the 10th grade, and they received additional 1-year training to become a health extension worker. But even after they serve 2 years and so on, they also upgrade to the next level, which we call a level 4 level, which is equivalent to advanced diploma level. So like most of, for example, among the 40,000 health extension workers, 60% of them, more than 60% of them are now level 4 health extension workers, which means they are 10th grade. They have a background of 10th grade, 10th grader. They received additional 1 year and also another 1.5 years. So they have also a better understanding of the health system, and also they were providing health service for the community for the last 15 years and 10 years. And they also received the training while doing their activities for the COVID-19 response. And mostly they are giving health education and also support the contact tracing and so on, and also house-to-house case finding. And also they receive training on what precaution measures they need to take, especially to prevent themselves. So one of the most important intervention, also what WHO recommends, is also to keep their physical distancing while doing their activities. And also they also receive PPEs like face masks and also alcohol-based hand sanitizers and so on. So in terms of education, I think they are better comparing to community health workers from other countries. Over to you.
Okay, so for us in Liberia, we have various cadres of community health workers. The first cadre of community health workers are professional health workers, and we have, the pool of professional health workers, nurses, midwives, physician assistants. We set our policy in a way that we have to tap on this human resource of the health system as the first layer of our community health workers. So these are professional health workers already trained in, for at the bachelor level, went through their routine nursing courses or midwifery courses or physician assistant to become a professional health worker. Then they are recruited and trained for additional couple of weeks into the community health strategy. The second group of community health workers are the ordinary folks living within their communities. These must be, as per our policy, must be either a high school graduate, but must be able to read with understanding and write. These ones are recruited from their communities, and they are given an intensive, an average of 50 days training into the community health strategy, and they are thereafter equipped with the requisite tools to be able to implement the activities. Now, between these two groups of people, we have the professional community health workers that serve as supervisors to these ordinary folks, providing daily mentoring and coaching to them, supervision and monitoring of their activity to make sure that they continue to do the right thing. So we have to strike that balance there if we are to maintain the quality of the program in Liberia. So they are both professional health workers who have already been doing the routine health services in health facilities, and have then transitioned into a community health worker as well as the ordinary folks. So a mixture of both in Liberia.
Thank you. And I'll ask Magnus to come in. And there's also a related question, Magnus, that maybe you can comment on, that is really specifically asking how is the training conducted for community health workers? So maybe you can start, and then I'll see if others want to complement.
Great, thank you. These are two great questions. The question about the terminology or the nomenclature, community health workers, is one that comes up frequently, and it is used in different forms in different countries. And I appreciate the clarification that both Temesgen and Olasford have provided. And as you can see, the use of that terminology in Liberia, for example, they have the community health assistants, which is referring to those frontline community health workers who are local community members. But in Ethiopia, they use the terminology health extension workers, again, reflecting those community-based extension workers. But the level of training or secondary school education that is used to determine who gets recruited into this program also varies from country to country. So essentially what we do from the Community Health Academy perspective, we tailor our training programs based on two things. One, the definition that is determined at country level by those ministries of health, the national policies in those countries, which determines the scope of work that community health workers are permitted to undertake. And it is that scope of work that also determines the depth and breadth of the training that you provide for community health workers at a country level. And it creates certain challenges of taking a one-step approach to training of community health workers. However, by working closely with ministries of health and allowing them to make the determination in terms of the various categories of the generic term community health workers and tailoring the training material, contextualizing it at country level to address the needs of whether it's nurses and midwives who already have a professional level of training, or those local community members that are recruited as frontline health workers to support their local communities that have a lower level of clinical training, and tailoring the training materials to address those needs. In terms of task shifting, because I think that's the kernel of the first question that was asked. What is the degree of task shifting? And why do we ask community members or community health workers to do one category of work or a range of activities? And why do we ask other health professionals to do other range of activities? It is all determined by the level of training that they have received previously. And now during an emergency response like this, how do we help to build the capacity of local community members to allow them or to prepare them to take on certain basic clinical activities to free up the time of nurses and midwives to do other things? So that's the way we contribute to building that capacity. In terms of the second question, how the training is provided, the Community Health Academy is taking a blended learning approach in terms of introduction of this digital platform. So some of the training is delivered through videos, animations, podcasts with gamification onto the mobile-based platform, which is an Android-based platform that the content can be downloaded, and once downloaded, community health workers can access this offline in their own time, go through the curriculum, go through the training materials, and then take quizzes to assess their level of knowledge and performance. It is not enough for them to do that just on the mobile platform. We believe that because this is clinical training, face-to-face training is still required, clinical skills lab training is still required, and in addition to that, practical placement, where under supervision, the supervisors, who are usually nurses and midwives, can supervise the community health workers to see if there is transfer of knowledge and skills gained through the learning platform and the skills lab, whether that knowledge and skills are being transferred to clinical practice. Because ultimately, it's the transfer of knowledge and skills into clinical practice that impacts the clinical outcomes of community members that community health workers are intervening with and supporting. So that's the approach the Academy is taking, and a number of countries are beginning to recognize the value of blended learning, so that it's not just this analog training that is done classroom face-to-face all the time that actually delivers quality of training translating into quality of care.
Thank you, Magnus. There is another question, and I'll ask Temesgen and Olisford to come in, but I know, Raj, you were also talking about this earlier. The question is whether the tracking of the contact tracing works 100%, if they can find all the contacts of the infected people, or is it very difficult to identify and contact everyone who's been in touch with an infected person, and what type of difficulties have those been? So maybe Temesgen, if I can start with you, because I don't see Olasford online, and then maybe Raj, you want to come in as well?
Thank you, Petra. So currently, like in our setup, the contact tracing is mostly done by the rapid response team. So under the surveillance team, there are rapid response teams at the national level, and also it's at each region. So there are currently, we can say like nearly 80 to 90% of the contacts are being identified, but there are still some difficulties because according to the definition of a contact, so there is a close contact and there is also a casual contact. So it's a little bit easier to find a close contact, but sometimes it's very difficult to get casual contacts. But like in our setup, since most of the cases currently being reported are from either from the quarantine, that means people who have a travel history, and most of them are being reported in the quarantine centers, and some people are also close contacts. So mostly the quarantine is being done, and as I said previously, the community health workers are also collaborating, especially in identifying the contacts and also in collaborating with the rapid response team in identifying the close contacts, and also joining the rapid response team so to get acceptance from the community. And in some places also even the security personnel are being joining them. But there is still difficulty because even the confirmed cases, they don't even remember who they have been in contact for the last 3 or 14 days before the symptom was appearing. For that purpose, currently we are also working in collaboration with our volunteers, especially technology volunteers, and we are developing a contact tracing app. So that app, it has a diary feature. So like everyone, like every day, they can register whom they contact in the day-to-day contacts, and also once we get a security clearance also from our information and also from the security personnel, it can also capture the contacts where around 2 meters, like for everyone. So if you open your Bluetooth in your phone, it can register all the contacts, the phone numbers of the contacts around you for the last 14 days and so. So once we get this type of application, it may help us especially for the contact tracing. But currently, the contact, it depends on the confirmed case. So he is the one who is going to tell you that he had contacted these people. But like if he forgets whom he contacts, it's a bit difficult. And mostly, as I said, our contact tracing is focused on the close contacts, not the casual contacts. So I think it is very difficult also to get all the contacts. But I think if we finalize this technology, it will help us also to do the contact tracing. Now it's in the testing phase, and it has really a good feature also for the contact tracing.
Thank you, Temesgen. And I'll go to Raj, and then I see that Derry Duoki, who's the Assistant Director for Community Health Services Division of the Ministry of Health in Liberia, is online. So I'll get him to respond to the same question on the contact tracing for Liberia. But Raj, why don't you start? Give Derry a moment to.
Sure. And welcome, Derry. I thought, Temesgen, your points were excellent. This is hard, but so the way I think about the 3 T's, testing, tracing, and treatment, right? These are things we have to do. I think of it as 10, 90, and 90. You want 10% of your testing rate, you want amongst your testing to have 10% or less to be positive. That's how you know whether you're doing enough testing. Your treatment should be that within 24 hours, someone should be of being confirmed positive, should be isolated if they're mild or sent to a treatment center if they're moderate or severe patients. The 90% within 24 hours. The tracing metric that we've seen other governments use is 90% of all confirmed cases have their contacts listed and identified within 24 hours of being confirmed. As is being implied in the question, this is very difficult to do, and Temesgen is highlighting some issues. But the positive news from the evidence is that contact tracing doesn't have to be perfect to work. In fact, there is a study which I'll share in the chat window You can tell I'm very active there. That researchers in the UK have used some modeling to simulate the effects of this, and they found, and this is research that's in preprint, so it's not peer-reviewed yet, to give that qualifier, but they found that if you could isolate symptomatic cases alone, that would drop transmission by 32%. If you combine isolation with manual contact tracing of all contacts, that reduced transmission by 61%. If contact tracing could only track down acquaintances, but not all contacts, the kind of scenario that Temesgen is highlighting, you could still reduce transmission of the virus by 57%. So this is saying to us that it is not, even if it's not done perfectly, you can't reach the 90% within 24 hours of all contacts being listed, and you can get halfway there. You will still have or partially there, I should say, you could still have an effect on transmission in a massive level. So I can share that link to this article from ProPublica where that cited this. So, and let me just say one last thing here. Many of you are working in countries where either there are no community health workers or the community health systems are quite weak. And so the government, all of you are thinking, I'm sure, about how to increase the human capacity, the staff capacity, the teams that would be needed to do contact tracing. Wuhan in China has 11 million people. The country of China had to train 1,800 contact tracing teams, each with 5 people on there. So 9,000 contact tracers just to get ahead of the epidemic in Wuhan and surrounding areas. So every country is going to need a significant number. And one of the opportunities you have, and perhaps Derry can speak to this, is Liberia was exactly in the same place. They did not have what Ethiopia had, which is a long 15 years of health extension workers when Ebola hit. They had informal volunteer workers, and many of them were insufficient. Derry could speak more to this, but Liberia then said, we're going to hire and train with supervision and proper PPE. 10,000 people stepped up to be contact tracers during the crisis in some form or another. After the crisis ended, there's a question, are you going to keep paying all of those people? The government said, no, we'll keep some of them in a volunteer mode in case we have the next crisis, but we will take 4,000 of them and turn them into paid workers. And they worked with the World Bank, the GFF, and many of you to make that possible, which is now putting them in a better position because they are now retraining those professionalized paid workers who have been part of the government of Liberia's, they're contracted by the government of Liberia, paid by domestic resources and other, to respond to COVID. And the finance minister and the president, both the prior one and the current one, found this appealing, not only because it helped with event-based surveillance for future epidemics, but also because it was a financial opportunity. The epidemic had caused such a massive economic impact, jobs were lost. So this was a chance for the health sector to contribute to creating jobs and creating and reducing unemployment as part of the economic recovery, which again, I think is another opportunity for all of us, is to help our country partners figure out things they can do now that will be important long-term, both for the health crisis and the economic crisis, and creating jobs for these workers in the short term and finding ways to sustain in the long term is one way to do that. Over.
Thank you, Raj. And I'm going to come back to you with a question on that has just come in. And I'm also going to ask Tsegane to then complement. But before I do, Derry, thank you so much for joining us. Do you want to elaborate a little bit more on the contact tracing in Liberia and any challenges you may see with that?
Thank you very much for bringing me on board. Currently in Liberia, the Community Health Assistance Program is actually working in the rural communities where we have the health facility beyond, we got communities that are beyond 5 kilometer radius of the existing health facilities. That is working well. But unlike urban city like Monrovia, where is the actual epicenter of the COVID-19, there was a plan to support the establishment of the community health program in 4 rural districts in Monserrado. And we were about to do mapping of the communities to determine exactly the number of community health service supervisor and the cadres of health workers to be deployed until the episode came about. With this response mechanism, with support from the Core Impact Project via Last Mile Health, WHO, FFO, we have been able to train 1,500 community health workers in Montserrat using the model that was displayed by my director last fall. So with that, they are serving into capacity on the contact tracing payload. They are case finder. When there is no contact, they are there to search for cases in the community. But whenever there's a case, they are now triggered to do contact tracing. With the contact tracing piece in Liberia, especially Monrovia, from the onset in February to March, it was a bit difficult where people were contacted and they switched their phones off. It was difficult to access them. But with vigorous community engagement, social mobilization, along the race communication payload, now people are now accepting that there is not a death warrant. So whenever they are listed as contact and follow up, they show up and they have been quarantined in local communities and precautionary observation center, and the result is getting fruitful. Another piece that we did on our community engagement payload with the community health workers was to work along with the community structure in the various community establishing structures. So with that, the community were able to come up with their own community action plan. For example, when there's a case in your community, before that case can be picked up, what can you do as a community? Working along with them, they were able to design their own community action plan, that which has been monitored by the volunteers and their supervisor. So with that, the issue of contact tracing have been enhanced, with the community themselves being on the alert, reporting those cases. But away from Monrovia, in the counties, the community health workers were already doing what we call community event-based surveillance. Whenever there's a strain scenario or strain disease in the community, look at the priority diseases that have been long listed by the country, they look at it, they serve as a trigger, and they alert the health facility or the immediate supervisors that do go and do the follow-up and verify those cases if it requires sample collection and whatever that is being done at that level. But with most of the challenges is in terms of geography, it's very vast and people move a lot. So sometimes to trace a contacts are moving from one place to another, they are tracing them. But with the involvement of the joint security and the various payloads on the IMS, I think we are on course and we are on path. We are directly working along with the payload lead for the contact tracing minister. We said we work closely with all, and we are also on that payload and ensuring that contacts are traced and quarantined and sent for testing. Over.
Thank you, Derry. And I remember not so long ago, we were having the discussion whereby you all raised the importance of having the community health workers in Monrovia. And congratulations to you for so quickly being able to scale up in this time. So I'm going to come to, I think, what may be the last question. So if anybody has any more questions, send them to me by email. But the question is about something we were discussing yesterday as well, about the payment and the sustainability. So obviously, a major issue with community health workers is pay and motivation, often because of lack of pay. In Liberia, the majority of community health workers were volunteers, and this seems to be the same across the board. How do you retain and motivate community health workers when only given a small stipend? Often they barely receive a salary and are asked to work daily within the community. And then linked to that is a question on how do you sustain community health workers because of budgets, dwindling donor resources, likely due to economic decline everywhere. So how to deal with this? I know, Raj, yesterday we had another session. We also talked about this. So maybe I'll get to you first, and then maybe Tsegane, if I could also ask you to add a few things, that'd be helpful. And others who may want to come in.
Yeah, I imagine Temesgen and Derry, who are would also have some interesting points on this. But I'm happy to lead, and thank you for that question. Just to clarify, for Liberia's example, which Derry can get into, they were unpaid. The government decided really for three reasons, which I think are security reasons, health security that is, moral reasons, and economic reasons to pay this cadre a minimum wage. They now get paid about $70 to $80 a month, which is minimum wage in Liberia, and 4,000 workers are on government contracts. Of course, Liberia is the third poorest country on earth. As we all know, GDP per capita is quite low. So Liberia is still investing about 13% of that from its domestic resources, which is pretty remarkable given how small their overall revenue pot is. And the remaining is coming from GFF, and the World Bank, USAID, Gavi, and the Global Fund, especially the malaria arm, because these workers are doing about 1/3 to 1/5 of all malaria testing and treatment in the country. They're also doing vaccinations in hard to reach areas. So Gavi has been involved. And then, of course, they're doing prenatal care. So each of these funders have said, as progress happens, we want to see Liberia increase its domestic resources. And these are not payroll-based workers. There's an argument that they should be, perhaps, but Liberia has said we're going to contract these workers. So there's not a benefits package, but there is a cash amount they get each month based on their performance. And every country does this differently. Magnus is creating a course on this, community health financing course that will be online, trying to get country experiences. But let me just clarify the three reasons that I think that's what's most important. Number one, during a crisis, I think it's clear to everyone the security of a nation depends on whether you can respond to epidemics, to test, to treat, to trace, to isolate. You cannot box in this virus without that. Community health workers, paying them, supporting them is critical for that. The second reason countries have adopted this is the moral one. Most of these community health workers are women in the world. Most of them are unpaid, as was noted by the question. We know that the WHO did a study last year, a gender equity and global health report, that showed when you count up the unpaid contributions of the poorest women, many of whom work as community health workers, to global health, that number is astronomical. It's $1 trillion of unpaid contributions by the poorest women on earth. In other words, they're subsidizing healthcare with their unpaid work. So there's just a plain moral reason for gender equity, for ensuring the poor. But the third one is actually something where the bank and all of you who are thinking about resource allocation decisions, the economic case is actually quite strong. So the World Bank put out a report called Investing in Strengthening Primary Healthcare by Investing in Community Health Workers, did an investment case, which again, we can share in the follow-up here, and that showed for every $1 invested in a community health worker, paying them, training them appropriately, supervising them, there's a 1 to 10 return to society. Every $1 returns $10. One of the key aspects is because it creates jobs for these workers. And so in these countries, and it's a great way to show and demonstrate, as Liberia proved, to the finance ministers that in fact health is not simply a cost, it can be an investment. And health can also contribute to job creation in underserved areas by employing young people and others. Lastly, there's an affordability estimate, and I'll turn it over back to you, Petra. Can a country as poor as Liberia afford this? What was done was an analysis that the World Bank team did, credit to them in Liberia, that showed, in fact, in the GFF investment case, drove this, that for adding payment to these workers, as well as training and equipment, professionalizing them, the 4,000 to cover 60% of the rural population, would only cost 4% of total health expenditure. So for 4% of total health expenditure increase, you can cover 60% of your rural population with a baseline of primary healthcare services as well as epidemic surveillance. So those were the arguments, security, moral, and economic, that countries have used to justify and rationalize the cost and investment here. Over.
Thank you, Raj.
Yes.
Tegane, go ahead.
Yeah. Hi.
And
Hi,
maybe
Petra.
introduce yourself, because not everybody has heard from you yet. We can't see you. Not sure if your video doesn't work, but we can hear you well.
Yeah, I'm Zagana Amsalu. I'm health economist in World Bank office in Ethiopia. And as you rightly mentioned, I wanted to act on sustainable financing while ensuring to this pandemic. And I think, as we were saying yesterday, what we learned in the past 40 or 50 years, when this type of either pandemics or nationwide epidemics have some opportunities attached to it, if we are able to convert it into using it to sustainable financing. Governments tend to start allocate more for health following this kind of health-related crisis. For instance, for example, what led for establishment or initiation of Ethiopian Health Extension Program is the malaria epidemic that has ravaged nearly 70% of the population in Ethiopia. It has affected 70% of the geographical areas in Ethiopia, and that has led for government to invest more on community health program at that time. And I will definitely sure that the health financing landscape in most of these low-income countries will not be the same after this COVID-19 crisis. So the way we approach it, either mobilizing resources from government or mobilized from partners, should be strategic in a way that we are able to sustain those resources after the pandemic. One of the things that experience tell us that the Ministry of Finance will be willing to relax some of the public financial management rules in this type of crisis management. One of this area might be allowing incentives to be provided for community health workers, which may not be the case in most of the cases. For example, in Ethiopia, health extension workers, they are on government payroll, they have a monthly salary, but there are many volunteer workers who are attached to health extension workers who doesn't take financial incentives. So this is the time that we strategically put those kind of public financial management rules that we wanted to change and to use the additional resource coming from government in this perspective. I think one of the other things I wanted to reflect on that I think there are more evidence are coming out with regard to the impact on delivery of essential health services and the need to maintain the delivery of essential health services. But we need to bring the financing aspect to it. Maintaining essential health services equates to maintaining the resources needed to it. So in the early periods of the COVID-19 response, most of the resource mobilizations are tended to reprogramming existing resource from essential services to COVID-19 response. So we should be in a position to make sure that unless resources are there, we are not to be able to avail the necessary essential services. So I think the use of evidences, the use of tracking resources, the use of looking into how service delivery is happening with regard to essential services and which resources being reprogrammed or moved away from essential service to COVID-19 really matters. And that has to be considered. And the last point, community health workers, in terms of number, they are huge. In Ethiopia, the number of health extension workers is the number of health workers working at the primary healthcare level is nearly 75% of the total health workers in the country. And the number of health extension workers, Women Development Army, is really huge. So any kind of resource projections for the COVID-19 response has to take into account the resource need for this segment of health workers. Like in terms of PPE, the personal protective equipment and other things. And unless they are taken into the calculations and the costing and the mapping, it will be very challenging at the end of the day to make them to be able to be part of the response. Over to you, Petra.
Thank you very much, Tsegane. That was very helpful. I'm going to ask Asiata, who has just joined us from Barry, can you give me 1 second? I just want to give Asiata, who has just joined us from Burkina Faso, the floor, because she has been writing us that in Burkina Faso, they also have started with mHealth COVID-19 with the use of tablets for self-monitoring by the general population and also for community-based health workers. So she would like to share their experience. Now, Assiata will speak in French. So if you're not speaking French, make sure on the left on your browser where it says at the bottom language selector, you select English so you can hear Assiata. Assiata is from UNICEF. Assiata, go ahead, please. Thank you for joining us.
Est-ce que vous pourriez, s'il vous plaît, s'il vous plaît, c'est au milieu de l'écran, la petite boîte du micro. Donc, je vais répéter si jamais. Donc, si vous pouvez ouvrir le micro. Donc, sur le centre de l'écran, une petite boîte rouge. No, I don't think we can get Assiata in the call right now.
Okay. Well, maybe Assiata, we had some colleagues from Burkina Faso on the call yesterday as well, and they also promised to share the manual. So maybe you can email me, because I don't think I received that yet from Burkina Faso. Maybe you can email it to me and we can make sure we make it available to everybody on the call, because we're always keen to share more experiences from more countries. So I think, was it Derry who wanted to come in? Or was it Magnus?
I wanted to make a quick point. Yeah, it was me. I just wanted to make a quick point about funding of community health work programs. And I want to come at this from the perspective of the health and well-being of a nation or the health outcomes within a country. It's not just the responsibility of the Ministry of Health. There are several other aspects of society that impacts on the health and well-being of communities, that are focusing on the Ministry of Health as the sole ministry to fund health programs, to fund community health worker programs for health outcomes at community level. It is actually something that a number of governments are reflecting on seriously and looking at how funding from either social services or from youth employment or from other ministries could also contribute to those type of programs. In Ghana, for example, what they did a number of years ago, as they were trying to build their community health worker programs, they brought in the Ministry of Youth Employment, who had funding to create employment for youths in the country, and took some of those resources to pay community health work programs, because then it created employment for youth in the country who then worked as community health workers. It's also possible for funding that is available for social services to be used to employ community health workers to a certain extent as a way of helping to provide health and social care services at the front lines. So that kind of creative thinking is what a number of countries are beginning to use to look at how resources could be repurposed from other ministries. Because as we all know, in Parliament, when debates are being held about resource allocation through the Ministry of Finance, all ministries are competing for the limited resources that the government has. And therefore, the health ministry always struggles to carve out enough funding to fund this type of health programs. And therefore, I think creative thinking, maybe those of us who are involved in global advocacy for community health worker programs could help to push this type of approach of using creative means of funding community health worker programs and not entirely dependent on funding that is available within the Ministry of Health. Over.
Thank you, Magnus. I think in this current climate, there's going to have to be a lot of creative thinking on many, many aspects. So I think that's a very important point that when it comes to resource allocation, where resources come from, as well as the responses. And I have received some questions on more details of how exactly certain things are done, how are protocols revised, and so on, which I think probably most logically for people is to see some of these examples of what has been done in Liberia and Ethiopia. So we're now 10 minutes past closing time. So I'm going to wrap it up. I will ask Ali Subandoro if he wants to say any final words from the GFF perspective. And maybe I'll start first with Madeleine. Madeleine, any final thoughts from your end?
I'll keep it brief. I'll just say that there are certainly a number of challenges, like we've discussed, but I think the key messages to take away from today are that health spending is going to come, whether it's in a disaster or whether it's to prepare for the disaster. We'd rather have it come in the latter form. There are a number of resources to help make sure that happens. We've been really active in the chat. They're in the document. We invite you also to contact us. I think Roz has dropped emails in the box below. This is an incredible community to exchange lessons with, and I know that you all have done it before in Ebola, and you'll do it again now in COVID-19.
Thanks, Madeleine. Ali, any final thoughts from you?
I guess just to be very short, just to reiterate from the GFF side, right, that we're in the times like this, we're really sort of supporting the country in terms of the maintain the essential service. And I think sort of this discussion with the community health workers, but very much place it into a context of the integrated primary health care to continue strengthening the system. I think it's very much in line with sort of the GFF support for the, sort of the system strengthening medium to long term. Thank you. Over.
Thanks, Ali. That's a very good way of summarizing the importance of why we started this webinar. And we're so pleased to invite colleagues from many different organizations working on this and having our friends from Ethiopia and Liberia share their experiences. I would like to thank you all very, very much. There'll be a summary note provided. There'll be a link to the webinar on our website. There'll be a link to resources that have all been shared today, so that everybody can access and reread any of this. And I would like to thank Madeleine, Magnus, Temesgen, Ali, Jerry, and of course Lasford, Tsegane, and Raj very, very much for a great, very informative session. I see lots of positive responses, and we know this role of community health workers is critical, this integration of the aspect of all levels of care to ensure we strengthen the system to provide essential services, as well as ensure we keep COVID as much at bay as we possibly can. With that, I would say stay healthy, stay safe, take good care. And we have our next webinar actually next week, which will be on health financing in view of COVID-19. So I'm sure a lot of what we were discussing at the end will also be picked up there again. So the liaison officers will be sharing the invites, and we look forward to seeing many of you there again. Thanks a lot.